Hey there, I am Dr. Amy King, otherwise known as Dr. Amy, and on this podcast, it is called The Most Important Medicine. If you don't know me, I'm a licensed psychologist, trainer, and consultant, and we're here to discuss how talking about trauma and providing a space for patients and providers to share their experiences is how we transform medicine. I work with physicians and healthcare organizations on the daily, and every time we begin these conversations, and I even hint at the discussion about trauma, I'm met with one of two things, either intense, compassionate curiosity and or a whole lot of skepticism. And that's what we're here for, to make understanding and discussing trauma accessible, and even more important, how to respond to trauma so that you feel more competent. Every time you join me, I want you to hear practical information and leave with tangible tools that you can use with patients today. So today I am so excited because I have my friend and special guest here today, Alfonso Ramirez. Alfonso holds a master's degree in counseling psychology from the University of Santa Monica, and he is certified in the neurosequential model of education and was a former sanctuary model trainer. Alfonso has provided consultation and training in education, healthcare, nonprofit, and governmental systems, and he is the owner of Trauma Informed Consulting, LLC. He recently led a successful 3-year trauma-informed schools pilot program at Tigard High School. During the pilot, Tigard experienced a significant decrease in disciplinary referrals and a significant increase in 4-year graduation rates. We will dive into this in the podcast today. But what is really notable is that there were higher increases for students receiving special education services, experiencing economic hardship, and for students of color. As a result of this work, Tigard High School was nominated for Washington County Public Health Department's Partner of the Year Award in both 2018 and 2019. And Tigard High School's trauma-informed work was featured in the HBO show Problem Areas with Wyatt, how do you say that? Cenac? Cenac. Mental health problems. Alfonso has experience with social emotional learning, healthcare policy, and equity, and he currently, and maybe most importantly, lives in Portland with his wife and 2 daughters. So welcome, Alfonso. I'm so glad you're here.
Thank you. I'm really excited to have this conversation with you today.
Me too. So that's kind of your formal intro. Anything else you would add about who you are or what you do?
I'm originally from Arizona, moved here about 10 years ago. And we thought we'd live in Portland just for a couple of years, but really it's been our home. Our kids have grown up here, and it's just amazing to be here and to meet people like you here in Oregon.
Yeah, and so for people that may be listening and not familiar, we're talking about Portland, Oregon, which is where Alfonso and I both live in areas around or surrounding, and we actually met at through Tigard Tualatin School District because we both had this synergy around trauma-informed trainings.
Yeah, part of our strategy was really to get parents involved and to educate parents around trauma, ACEs, and resilience. Most importantly, resilience and what they could do to help bolster that with their kids. And I had seen you present, I think, to some pediatricians, and I thought, wow, it would be great if we could get Amy to come talk to our parents. And it was really, I don't know if we shared the data with you, but probably one of our most successful events. I mean, every parent enjoyed it. And I think it was something like 95% of them would have recommended you to talk to other people. So I'm just really appreciative of you coming and having that conversation with us.
Well, and you know what I learned from working with that group as well, we started with, I can't remember our initial number, and every time we had another presentation, those numbers grew because people felt safe, they felt respected, they felt like they were in community. And that wasn't just because of information I was providing, but what you were doing in the schools, what the community was doing, what the teachers were doing. So I can't wait to talk more about that. But let me back up. So Alfonso is a really humble friend of mine, but he is brilliant when it comes to trauma-informed work and a really commitment to diversity and equity in the work that we do, whether it be in education or healthcare systems. So can we back up a little bit, Alfonso, and would you do me a favor and define trauma in your own words?
So for me, when I think of trauma, it's really sort of the effect. I kind of subscribe to the 3 E's that Samsa talks about. It's really the effect that an event has had on somebody. And it's, again, really an experience. So I think of effect, experience, an event, and the thing I will add to it though is it's not just an individual experience, but it can be a collective experience held within a community. And I think sometimes that's left out.
I 100% agree. On this particular podcast, we're talking about trauma-informed medicine and trauma-informed work in healthcare organizations. What I just heard you say is really important, right? Because a physician or healthcare provider might look at something someone's gone through and think, well, that doesn't seem traumatic. But you said it is an effect that it has on the individual, their experience of the event. Can you say a little bit more about that?
Yeah, I think for some of us, for example, maybe there's a divorce that happens, and depending on the person, that could have a lifelong effect. And for others, it may be a year or two. So I think it just really depends on a number of factors. And trauma seems to be like that. The more connections we have with people, the more we sense belonging and that we matter with the people around us. It could really buffer the effects of whatever event, whether it's a hurricane, whether it's divorce, whether it's some other traumatic impact.
And you mentioned that a trauma could be something that happens to an individual, right? Like a divorce or bullying or discrimination, or it could be something that happens to an entire community of people.
Yeah, exactly. I shared a little bit about this, but in some of my LinkedIn posts, but I was actually about a mile away from the El Paso shooting that occurred. I think it was something like 26 individuals were killed. That's an example of really a community trauma that people experience. And El Paso, if you know that place, is it's like the biggest small town in the world. I mean, people are really connected. So that's something I think that will, take a few years for the community to get over. But one of the things I do like about that town is that people do connect with each other. There are a lot of there's just a big sense of community and pride, and I think that's something that is definitely going to help.
Yeah, one thing I've learned through this work is that no matter how aware you try to be of trauma that might happen, if we watch the news, if we pay attention to politics, right, there's still traumas that happen in communities that we might not know about if we're not a member or a part of that community or that neighborhood. Is that right?
Yeah, absolutely. Really, the thing that flashes to my mind was one of my first trauma-informed trainings is when I was doing work around the sanctuary model. And someone had talked about, I think it was an event that happened in sort of Eastern Oregon with the Rajneeshis.
Yes, right.
And one thing she said is that you won't find any salad bars in our area. And it sort of really blew me away. I was like, well, why not? Because the salad bars are where people had been poisoned during this time. And so if you weren't a member of that community, if you weren't there during that time, you would maybe just think it's odd. There's no salad bars, but there's really that. And I don't know what it's like now. I mean, it could be back, but I think there's these little things that can happen. And that's probably more visible than other things.
You mentioned the sanctuary model. I'll put a link to the sanctuary model in the show notes, but would you mind describing briefly what that means or what that is for people who might not be aware?
Yeah, the sanctuary model was a model that was developed by Sandy Bloom, and it had some pillars that were really centered around a community experience, and really, finding ways to really be in community differently. And there were protocols and ways to communicate that. There were check-ins, and it was really like, how do we use this the community that we're in to really bolster each other.
Yeah. I'm familiar as well with the self-healing model of communities by Laura Porter. And she really talks about how communities inherently have the ability to heal themselves when we listen, and when we listen to their health educators and elders that are in those communities that have really important lived experiences. So on this podcast, we talk about how trauma can present in the field of medicine, sometimes overtly, sometimes subtly. And one of your areas of specialty is not just trauma-informed work, but how that intersects with health equity. Can you, first of all, define for us what is health equity?
Well, I'll tell you, to me, when I think of health equity, I think first of an acknowledgement that there are inequities, and that these inequities exist primarily due to biases in our society and in our systems. And it's really aiming to ensure that every person has the opportunities and resources necessary to fulfill their, full health potential. And that's really about, us as people working in these systems, really sharing and redistributing our power and resources to those that are most impacted by health inequities, and recognizing sort of historical and contemporary injustices, rectifying them, reconciling them when we can.
Okay, so again, for people who might not be familiar, let's break this down a little bit. What would be an example of an inherent bias in a health system that would create inequity?
Well, to make it even a little bit easier, let me go to a school system.
Okay, great.
And during our trauma-informed pilot, we saw a 40% decline in disciplinary referrals, so kids that were sent to the office. And
40.
when we looked a little
40, I want everybody to hear that. 40, right?
Yeah, thank you. Yeah, 40% decline. And I was walking in the hall one day, and I was talking to one of our female students, and he said, we were talking about that. And she said, that may be true, but I never get asked for my hall pass when I'm walking through the hallway. And so when I looked a little deeper, the disparities, even though everybody's disciplinary referrals went down, the disparities didn't change. There were mostly Black and brown kids that were sent to the office. And this kind of led me to really kind of question why that was. And and that occurs in many different places in healthcare settings. They're really the biases that we hold that we don't know that we hold. There's something that tells us, hey, let's ask for this Black or brown kids pass, and probably a male. I don't have to ask this white female student for their pass because they're probably okay. So it's those little biases that cause these inequities, not just in school, but in healthcare as well.
Well, and I think about things in healthcare like we know that there's a higher rate of mortality amongst Black women who are pregnant, for instance, or even some of the biases that may be present in terms of access to healthcare. So then we start to think about things like intersections of equity and historical traumas, right?
Yep.
When groups of people may have felt like the healthcare system was not really set up to serve them, to help them.
Yeah, it's interesting that when Black women get care by other Black doctors, those statistics actually get better, and they actually do better.
Mm-hmm.
But I'll tell you, it is tied, to our society as well. There's a great 15-minute video called "If Cells Could Talk," and
Yes.
this is done by Dr. Candice Watson.
Mm-hmm.
And, really what we think about when we think of protective factors, we think of education. If you go to college, get a master's degree, bachelor's degree, whatever, that is actually a good indicator of how healthy you'll be. And what he did is he studied Black men at the University of California at Los Angeles, UCLA. And what he found was that 1/3 of these Black men had telomeres that were the same size as women that were twice their age that had who had twice their age and had survived breast cancer. So for those that don't know, telomeres are sort of the end caps of our cells, and the longer they are, the healthier they are. And as we, take trips around the sun, they shorten as we get older. And so it was really quite astonishing that a third of these men really had shortened telomeres. And so
to break it down, right? Because Alfonso and I both, neither of us are physicians, but this is a really important thing for people to know. And I think in lay terms, what we can say is we want long telomeres, right? And we want to be able to look at our telomeres and go, that equates to life expectancy, or kind of, as you were saying, trips around the sun, right? And when in this particular study, when they were looking at Black men, they had the same length of telomeres as women twice their age who had survived breast cancer. What does that mean on a practical level about that man? And I know we're generalizing to population health, but what would that mean?
So to me, it means that a third of these men really weren't well, and they were brilliant. They were at UCLA, and those are really like, protective factors, but for them, for some reason, it hadn't been. And so, Dr. Ken just asked them all a question. He said, have you experienced microaggressions? And for those that don't know, microaggressions are sort of these daily invalidations of you because of the color of your skin, your culture, your ethnicity, your social status. And so about half of the men said, yes, I experienced microaggressions. And the other half said, I don't experience microaggressions. And so what he thought was that those that experienced microaggressions would have the shortest unhealthy telomeres, and those that hadn't would have longer ones. And what he found was the reverse. That actually those that experienced microaggressions and could talk about it actually had longer telomeres. And he was trying to figure this out. And what he came up with was, well, understanding what a microaggression is, understanding what biases are, helps you navigate them. And that is a protective factor. But if you don't even know what they are, or you don't believe you even have permission to acknowledge that things are unfair and biased, that's really what's unhealthy. And it made me, personally, I was working in a school district, but, I can apply this as a clinician as well. And I think it goes true with any trauma survivor. We have to acknowledge their experience. And if someone says, I've experienced racism or microaggressions, or have I experienced, child abuse, or whatever it is, it's really important for us to understand their perspective and to believe them.
Yes. And it goes back to what you said before, the effect an event has on that particular individual. It's their experience, not your interpretation of that experience.
Absolutely.
Yeah. I'll link up to some resources for folks in the show notes around microaggressions too, because I think sometimes people who don't understand, they hear micro and they think small.
Yes.
Micro doesn't mean small. It means those daily insults that occur to someone because of their race, their gender, their ethnicity, their ableism, their socioeconomic background, et cetera. It's these recurring stressors.
Yeah. And I think one of the things that we could do is when we, to kind of see if we're putting out microaggressions, is just to check in with your body. How are you feeling in a certain situation? If you're feeling uncomfortable, there's probably something going on there, and there may be a microaggression that you may not even know that you're putting out. But one thing I want to say, because I think this is really important, is what Dr. Ken just found is that bringing people together to have, sort of these healing circles, time to talk, that actually can reverse the impact of trauma, and your telomeres can actually grow back. So that was something that they found, in particular with the person in the video, that, actually their telomeres stopped shortening, and actually they started healing. And that is really, really powerful.
And I know that that's where you and I connect and have so much synergy, right? Because I know we both believe we want to acknowledge trauma and we want to give people hope about healing. And so this idea that you could bring together a group of people who could understand those biases more, talk through them, work through them, actually will begin to heal neurobiologically within your body
Yeah.
so that you could live. That's incredible.
And at least from my experience, it's not just healing for the person on the receiving end of microaggressions, it's healing for us too.
Right. Yeah. So going back to this idea about health equity and how it may present subtly or overtly, what about for the person on the receiving end, Alfonso? What about the person who is Black or brown or has a disability or identifies as LGBTQ plus, and they're feeling that feeling, like you said, in their body, like, this doesn't feel right. I wish I could say more to my provider or advocate, or I don't understand what would you say to that person?
I would say trust your instincts.
Mhm.
Trust yourself, realize you're not alone, reach out to other people that have had those experiences, and really give yourself permission to feel those feelings. A lot of times it's uncomfortable. And speaking as a man of color, I've been in situations that haven't been uncomfortable, and I have told myself, that you're just making that up. That isn't really true. That's not what they meant. But allowing yourself really to just think that it might be, and that in and of itself can be somewhat depressing when you realize, oh yeah, there are biases in the world, and there's biases against me. But I think, connecting with other people, connecting with professionals that share your experience, your identity can also be helpful.
Yeah, I love what you just said about Black moms who were seeing Black physicians did better in their care, probably for advocacy, for affinity.
Yeah, absolutely. And I think, all of us, even if we don't share the identity as the person that we're working with, can still be culturally responsive.
Mm.
We can still be that safe person to say, yes, I hear you. Yes, you're right. I believe you. I believe that that's been your experience. And I'm committed to being, responsive.
Yeah. Culturally responsive, to believe someone, to believe their experience. That's huge, right?
Yeah, and to be open to their own health beliefs.
Mhm.
Really our systems are really built on Eurocentric models. And I'll tell you another story that I had when I was working in a school district. I was working at a school for Tana Otham tribal members, and that's, if you don't know, the Otham are the second largest tribe in the United States. And this woman said, in the 50s, we would have this system on the reservation where if there was a car accident, we try to have them work it out. And the
Mhm.
federal government said, no, there has to be a winner and a loser. Someone has to be at blame for the accident.
Interesting.
And this was like in the 90s, 2000s. And then she said, later on, when we switched everything to there's a winner and a loser, someone to blame for it, they said, hey, why don't you do mediation? Why don't you see if they can work it out?
Mhm.
And they're like, wow, that's what we tried to do 30 years ago, but you didn't let us. So I think, there's a lot of value in really listening to the cultural wisdom and traditions that people have held. And I think that's part of being culturally responsive, is really being able to lean into how other people experience health, and to really listen and learn as well.
So I just want to underscore that it wasn't until the people in power had that idea that
Yeah,
then it was acceptable.
yeah, exactly.
Yeah, that's chilling to me. How does, what might be some other examples of health inequities or how we could respond to it? Like, I think about entire groups of people who may have been mistreated in medical systems, and then they come into, one person for instance comes into an office and they might seem irritable with the front office staff, or they might be labeled as non-compliant in their behavior. How do you read through that as someone who's trauma informed?
Yeah, I see cultural responsiveness sort of in the same light as trauma informed.
Mhm.
That when somebody comes in the front door, there's a cultural responsiveness or a responsive approach. When they go up to the front office and they check themselves in, there's a cultural responsiveness approach. And it's this, very synonymous with being trauma informed. The one thing I'll say about this trauma informed movement is it's really rooted in understanding our neurobiology.
Right, right.
And that is just, it's the same brain, it's the same functioning when you're doing, health equity as well. Like really listen in to your own body as a practitioner. And if you're feeling uncomfortable, then, check it out. Why is that? Is there a bias there? Is there something, you can speak to your colleagues, get support from your supervisor to try to sort of unpack what it is that you're experiencing.
Mhm. Are there other ways that you educate others on how this shows up? Like, if you were talking to professionals, how might this show up?
Yeah. So I'll take a little bit of a detour to talk a little bit about this iceberg model that I think is super important.
Oh, great. Yeah.
When we think of these, think of health inequity like an iceberg. And up at the top, we have these really inequitable outcomes. And just above the surface of the water, we have actions that we take. And a lot of times what we try to do is we try to take different actions. Well, I'm going to change this policy, or I'm going to change this practice.
Mhm.
But really, it's what's underneath the water, the deepest part of the iceberg, where the change needs to occur. So it's in the conversations that we're having, but even below that, it's really in the perceptions and beliefs that we have to unpack. And it's best to do that collectively. It's best to come together in groups with other staff, with other pediatricians or other doctors, and really talk about, let's look at our outcomes. What are some of the biases that may be present?
Mhm.
And even more powerful than that is to listen to the people that are receiving our services. They could be customer surveys, they could be qualitative assessments, and the little things that people kind of drop by from time to time. The little comments that they make that could provide a wealth of information about what your system feels like to a person of color or a member of the LGBTQ IA2S plus community. Those little things can be really helpful. So when I think of like, what do we want to do? We want to listen to our patients or our clients, and really to learn and heal listen and learn, and really to kind of heal ourselves, because that's really what healing is about changing these biases, changing the misperceptions that we have, and really responding back to them. Really understanding, is this what I heard? Are you feeling uncomfortable because of this? Is this something that you're experiencing? Wow, I don't want that to happen. I'd love to do things differently. So those are all little things that we can do.
Okay, so I'm hearing some really, really great nuggets from Alfonso that I want y'all to listen to. One, meet together as a group, right? Whether you're a clinic or a healthcare organization, or meet together and look at data. It might be quantitative data, but often it sounds like it's in that qualitative data, these small little encounters where someone might be sharing with you an experience that they had, and be willing to be open to it and think about like, oh gosh, maybe there was a bias present there, or maybe I hadn't thought about the patient in this way, and be willing to just kind of crack it open and sit with it.
Yeah, I'll tell you one thing that somebody told me that was a cool little nugget was they were Latino, and they said Latinos don't value healthcare, or no, they said Latinos don't value mental health.
Mhm.
And so you can hear that and you could think, oh, well, they don't care. Or you can say, or you can listen and really hear, oh, our behavioral health doesn't provide meaning or value to this community. So it's not like they don't value mental health. It's that there's this mismatch. And so how can I learn what mental health means to this person, what wellness means, and how can I do a better job of connecting and making it align with that.
So I love this example. Let's use that example of this particular person who may have given that feedback, right? And now you want to circle back as a provider or as a clinic. Do you go back to that person, Alfonso, and expect them to be kind of an educator? Or do you go to a professional for some more information? What would you advise someone who is looking for, like, how do we repair and learn?
I think it's good to have connections with culturally specific providers, and honestly, if the services that you're providing you feel like aren't helpful and potentially harmful, then if you have relationships with a culturally specific provider, that might be a good referral. But also you can reach out to them. You can do some research, and I think it's actually perfectly okay to say, hey, when you said that comment, it just made me think that my approach wasn't working. Tell me about what tends to work with you, or how do you view wellness? What does wellness mean to you? What would an ideal scene be? How can I help meet what is important to you?
Yeah, it's so important to remember, I've yet to meet someone, regardless of their background, who doesn't want to be well, who doesn't want their kids to be healthy and happy and contributing individuals. And yet there's a lot of systems that get in the way of that.
Yeah, and I just really appreciated what you just said, because I think part of health equity is having that belief that everyone is committed to wellness. Everyone wants their children to be well. There's not one parent that doesn't want their children to be well. And even though they may be suffering with addiction or other sort of ailments, it doesn't mean that they don't want their children to be well, or they don't want to be well themselves.
Yeah, I always kind of ask this question, like, okay, if I'm meeting with this patient or this client, and it seems like there's a barrier, right, to their wellness, what I might identify as health or wellness, right, which is my own bias, right, because I have my own definition of what that might mean, or the time frame it should happen in, or how it would look. If I perceive a barrier, it is so important to just kind of check myself and go, okay, maybe I'm the barrier.
Yes.
Maybe the system is the barrier. Maybe the language is the barrier, because I have to believe that this person, family, individual, whoever it is sitting in front of me, wants a prosperous, healthy life.
Absolutely. And I think, like, holding that hope that things can be better for this person. I think that's also, I think sometimes we give up and think, oh, there's nothing I can do for this person. And that's really maybe even an element of trauma speaking. But I think holding that vision and holding that hope is important. I do have actually another suggestion when it comes to health equity, if I could share it. And this might not be something that we always remember, but humanizing our systems. What I find is when we're overworked and when we're stressed, the biases really live in the lower parts of the brain, in the brainstem. And if we don't have environments where we can be humanized, where we can feel, creative, it's really hard to do any kind of equity work if we ourselves are not taking care of ourselves and each other.
This to me is so critically important, Alfonso. So if I'm a healthcare provider or an organization or a physician who's listening to this, and I think, well, how's this good for me, right? Like, why do I need to be learning more about this, committing to work that is equitable for my patients? You just named it, right? That if we're not able to humanize our systems, it's going to affect the patient. It's going to affect you as a provider. I mean, that seems like everything to me.
Yeah, absolutely.
Wow. Okay. Let me see. Well, let me ask you something related. Why is this work important to you? And why should it be important to other providers?
Yeah, you know, primarily it's because we all need each other. You know, we really need each other to be well. And if you're not well, it's hard for me to be as well as I can be. And, you know, we all encounter each other out in the streets, you know, at the park, online. Unfortunately, more and more online than out in public. But, you know, you know, our kids, you know, play together. We want everybody to be well. And the one thing I've sort of have found or believed to be true is that, you know, those that are the most impacted by health inequities, when they do better, all of us do better. All of us do well. One thing we found with the trauma-informed pilot at Tigard High School is sort of this, you know, closing of the gap, but everybody got better. We had a 7% increase for everyone. You know, Black and brown kids did better. Kids with special education needs, they did better. White kids did better. Everybody got better.
Wow.
And so I think like the more that we really lean into health equity, I just think it makes everyone healthier.
I have to, I'm going to admit, those of you that are listening via audio and not watching the video, I'm a little tearful as I hear Alfonso say this, right? But I really am so passionate that people know this. And I'm just going to repeat what you said, your words, not mine. If I'm not well, you're not well. And if you're not well, our community's not well. And when we all are focused on health equity, everybody's going to get better. Everybody's going to get better. Oh my gosh. Which answers my other question, which is why should we be talking about this more? And we should just clearly be talking about this more. Do you have any practical comments or questions that in a way that you talk or ask about health equity in healthcare settings that you found to be really helpful? Like, how do you open those discussions?
So, you know, in terms of like working with the patient or working with colleagues or,
yeah, let's
or
say
any of that?
that's a great question. So first with colleagues, right?
Well, one thing I like to do is there's a protocol that I like to use. It's called the first thought, second thought protocol.
I love this. Good.
And the first thought, you can just assume that the first thing you think about has bias in it. There's probably some prejudice. There's something about it.
Give us an example. Give us an example.
Okay. I might say, you know, if I'm working with, let's say I'm working with somebody that's experienced some trauma. My first thought may be it's the parent's fault. And so that's just a bias that I have, but there's, you know, a million biases that we have when we're talking. But if you can get everybody just to say, oh, okay, let's just all agree that our first thoughts are biased and have everybody share what they're thinking. Then we can move to a second thought, because then we hear what everybody else is saying. And even though there's biases in there, there are probably some things that are going to different, because everyone's had a different perspective or a different experience in life. And especially the more diverse or inclusive that group is, you're going to be able to get to a second thought of where you want to strive to be. So if you say, hey, we noticed that we don't get a lot of people of color in our clinic. I wonder why that is. And share your first thoughts.
Great. They don't care.
They're in a group.
They're not interested in their health. You know, whatever their first thought is, right?
Whatever the first thought is. But as people, you know, begin to share, especially if you have a diverse group, well, maybe we aren't providing the type of service that they need. Maybe they're scared. Maybe
language barrier.
Maybe I'm scared and they can feel that. Whatever those are, but they'll get you to sort of second thoughts. So we call it the first thought, second thought protocol. And honestly, we're always moving to like third thoughts, fourth thoughts. That works. And the thing is, it really normalizes collective thinking versus individual thinking. Because if we're left to try to solve the problem on our own, it's really hard. But
Well,
if we can elicit the support,
yeah, right, to be in groups.
yeah.
Let me give listeners, so I actually just did Alfonso's exercise because I love first thought, second thought in a training I did last week with a really big pediatric group. And what I said to them was in their team huddle, describe for me, quote, difficult patient behavior. And man, the chat box just lit up, right? What is difficult patient behavior? Not showing up on time, not making eye contact, refusing medication, missing appointments, angry patients, patients who raise their voices at you, this whole slew of, their first thought was, this is my description of difficult patient behavior. And then we talked about what it means to be a trauma-aware clinic, what it means to have cultural humility when it comes to thinking about people's behavior. And I said, now let's go back to our difficult patients. What might be another reason? Just look at the behaviors that were listed that they may be acting that way. And all of a sudden, I saw, Alfonso, people tear up, people turn their cameras off on Zoom, people begin to light up the chat box again, like maybe they didn't feel heard, maybe they didn't understand the medical jargon you were using, maybe they had just come from a really difficult experience earlier, and you saw so much compassion in the second round. It was incredible. So for those of you listening, use Alfonso's protocol, first question, second question, or first round, second round. It really elicits beautiful conversations.
Yeah, and I have to say I got that from Zinnia from the Tiger Tualatin School District. So I wanted to credit her for that.
Zinnia, yes.
That process. I think and the way that you talked about it is like you have this first thoughts, let's get them out on the table. Then let's think, let's have a sort of a presentation, or let's provide some information. And then you go to the second thought. It really like gets people moving and thinking in a different way, which is super important.
I love that. I know we're coming to the close of our time right now, so I have just a few rapid fire questions. Are you ready?
Okay.
Okay. What is one thing you think people get wrong about trauma-informed work?
One thing they get wrong. Honestly, sometimes what I hear is they don't broaden trauma to include things like microaggression, racial trauma. I think that's something that we're doing better at, but initially we sort of didn't include and got wrong.
Yeah, agree. So if you had to go back, you've done training in it, you've worked in so many different areas and arenas and backgrounds. If you could go back to young Alfonso, who was just starting out in this work, what would you say to him?
It's funny when you said young Alfonso, I pictured myself in like the third grade. And it was like, and one of the things I would have told him or would have explored with him was regulation, self-regulation, self-love, self-compassion. I think those are the things. And maybe, starting out in this work, it can be really challenging. So I think probably the same thing, self-regulation, self-compassion, and permission to explore.
Yeah. Oh, I hope everybody heard that. We can all do better, right? Self-love, self-regulation, self-compassion. Okay, so 2 more questions. In healthcare, you mentioned it before, it's often a Eurocentric model that comes up. And I think people feel like those in healthcare are like the utmost professionals. They never make mistakes, right? They have to just be consummate, like stoic beings. What, for you, what's one kind of a perfectly imperfect thing about you that you wouldn't mind sharing? Like something that makes you just a messy human being like the rest of us.
A messy human being. I'm a, and maybe you've noticed this about me, but I'm a little quirky. There are things that probably, I shouldn't ask, but there's this little kid in me that just wants to know,
It's the
So
third grader. It's the third grader in you. You
it's
just
the third grader. Yeah, exactly.
yeah.
So I'm just a little quirky at times, but I think, over the years, and maybe this is something I would tell that you just learn to kind of embrace your quirkiness as much as you can.
Oh, I love that. I love that. Okay, last question. It's 11 o'clock at night and you have a food craving. What do you reach for?
No longer pistachios. I had some pistachios last night and I had a hard time sleeping after that. My food craving, believe it or not, this is part of my quirkiness. And it ties into the third grade, because it was in the third grade when I first tried Doritos in a class party. And
Okay.
I've been hooked ever since. So 11 p.m., I crave Doritos.
Okay, Cool Ranch or nacho?
The regular nacho, not even the spicy. I love Doritos. I don't know what it is.
That's awesome. If people want to learn more about your work, what's the best way to reach you?
They can reach me at traumainformedconsulting@gmail.com.
Awesome.
And they can also reach out to my website, which is Alfonso Ramirez Jr. Jr. .com.
Perfect. We will put that in the show notes for everyone. But let me just take a minute to say thank you from the bottom of my heart. I have loved working with you and getting to know you over the years. Your is always in the right place, Alfonso, and you're an inspiration to people that work with you and know you. And I think in order to do this work, it has to be heart-centered work. And you're such a beautiful model of a human being doing this work. So thank you for joining me.
Yeah, thank you, Amy. And I feel the same way about you. I've just really appreciated getting to know you and all the opportunities we've had to collaborate and work together.
Me too. Thank you.
Thank you.